Thank you, Bob, and thank you to Endothelics and Vasomedical for this fascinating evening of entertainment and science. It's great. So I have a few slides only. I'm going to focus fairly closely on my topic of endothelial dysfunction in different cardiovascular disease risk states, which may be quite relevant, thank you, to tonight's topic. Endothelial dysfunction, as we'll see, many of you already know, is a precursor to many of the situations that lead to myocardial infarction, stroke, cardiovascular disease, and premature death. And one of the ways in which it's studied in human subjects, fascinatingly, is to cause ischemia of a limb for 5 minutes and then to release the cuff and to study the flow-mediated vasodilation, which is endothelium dependent, which is really exactly what we're talking about tonight, is also a therapeutic modality, whereas we use it as a diagnostic modality in terms of endothelial function, which begins to, I think, develop a thread between endothelial function and dysfunction on the one hand and remote preconditioning on the other, which I think is rather fascinating. So endothelial function was discovered by Wilcox some 30 years ago, in which he stimulated the endothelium of blood vessels with acetylcholine, found it released a factor that caused vasorelaxation, and we later found also improved the integrity of the blood vessel, made it less leaky and less thrombotic. All the things you'd like to have in your blood vessels if you want to remain healthy and free from cardiovascular disease. And later on, others identified the main molecule as nitric oxide. So I'll focus on nitric oxide tonight. I know there are other pathways to endothelial function, but nitric oxide is of predominant importance. We've known for a long time that there are a number of factors summarized in this slide which regulate nitric oxide synthase and nitric oxide production. But only two factors are well described which inhibit nitric oxide synthase or nitric oxide production. Asymmetric dimethylarginine, which is a circulating inhibitor of nitric oxide synthase, and factors that generate oxidative stress, which oxidize a critical cofactor and actually turn nitric oxide synthase from being a protective factor, generating the wanted nitric oxide, to being an aggressive factor as the enzyme falls apart, generating more superoxide. So, what are the factors associated with oxidative stress in human subjects? And the best, I think, gold standard for a marker of oxidative stress is isoprostanes, because these are formed non-enzymically by the interaction of superoxide, specifically with arachidonate. An 8-isoprostane is a stable end product, and therefore its accumulation in the blood or its secretion in the urine gives insight into the frequency with which superoxide meets arachidonic acid, and therefore by extension oxidative stress. And you'll see a sort of monotonous pattern here, that hypertension, renovascular disease, diabetes, coronary artery disease, smokers, hypercholesterolemic subjects, and obese subjects, this is just part of an endless list, all well-categorized risk factors for cardiovascular disease are associated with a rather robust increase in the plasma level or rate of excretion of this marker of oxidative stress, and therefore are believed to be syndromes of oxidative stress in human subjects, therefore raising the possibility that oxidative stress and endothelial dysfunction is a more or less universal preconditioning factor for later cardiovascular catastrophe. Equally impressive is the epidemiologic evidence for ADMA, just summarized very briefly here. You'll see if we look at older subjects, patients with incipient renal disease or severe renal disease, hypercholesterolemia or peripheral vascular disease, again, the plasma levels of this endogenous nitric oxide synthase inhibitor are fairly universally increased. And this leads us to our view of cardiovascular and kidney disease, which is really a pyramid of effector processes, but we place oxidative stress at or close to the top because it appears to be uniformly associated with oxidative stress, with the outcomes. And in our recent studies, we've been able to show that ADMA is directly produced by oxidative stress in cells and therefore is a downstream effector pathway. So our view would be summarized here, if you like, that all these established and developing cardiovascular risk factors are associated with evidence of reactive oxygen species and/or ADMA in the circulation or tissues. And a number of studies by basic scientists and clinical investigators have shown that either or both of these factors can induce events in blood vessels and organs which are clearly deleterious and lead to the potential for cardiovascular disease. So here, which is the culprit, ADMA or oxidative stress? And our data, as I've said, rather suggest a synthesis that probably oxidative stress is driving the ADMA upwards, and they act as unwanted guests at the cardiovascular risk table. So very briefly, how might we assess this more directly in human subjects? And we have, of course, beautiful indirect methods that may be the subject of future discussions tonight. But we, being physiologists, wish to look at the vessel directly so that we can establish not just unequivocal endothelial function versus dysfunction, but begin to identify the genes and pathways that might be involved. And here we've used the technique of gluteal biopsy, so that subjects under a local anesthesia with the help of a surgeon have a small segment of skin removed from the gluteal region with the subcutaneous tissue underneath it, about a cubic centimeter. We take it to the laboratory where we have very skilled macrovascular physiologists who dissect these subdermal microvessels, set them up in a myograph and measure the isometric tension developed so that we can study directly endothelial function in human macrovessels. Then when we do this, for example, we take here a group of patients with CKD1. So the only reason we knew they had CKD is that we knew that they had cysts in the kidney, they had polycystic kidney disease. As you'll see at the bottom here, their GFR was unequivocally normal when measured by a creatinine-independent method, as was their blood pressure measured by ambulatory methods. So they were right at the beginning of chronic kidney disease, a very earliest step, we might say. But already their blood vessels have a profound defect in endothelium-derived nitric oxide, as shown. The green are the controls, the age-matched controls, and the red the patients. And we could measure nitric oxide synthase activity directly from the conversion of radio-labeled arginine to citrulline in these vessels, and you'll see it was about 80% impaired. And we had some correlation or validation at the whole human level that their nitric oxide synthase metabolite excretion was also reduced. So was this ADMA or oxidative stress? And we couldn't differentiate here because both plasma ADMA was increased in panel D and another index, HOD, actually another oxidized fatty acid that we happen to use on this occasion, was also elevated. But as I've mentioned, these are probably on the same pathway, and therefore we shouldn't expect to see them differentiated in a study like this. So with this technique, we've gone on and studied human essential hypertension, and these are patients, subjects I should say really, at the very beginning of hypertension, before there's any cardiovascular complications, and more recently young ladies with unfortunate enough to have HIV, in whom there's premature aging and premature cardiovascular disease. And this group, without any other cardiovascular risk factors, have profound endothelial dysfunction. I'm not going to show you the data because it's rather repetitive. It looks just like you saw with the early kidney disease. So what I've learned from these studies is the extraordinary stage at which endothelial function begins in human subjects. These are very, very early stages in the disease, I think you'd agree, and the degree of endothelial function rather profound, which again I think fits with our prejudice that this is an early event in the cascade that leads ultimately to catastrophic cardiovascular consequences. Thank you very much.